Hi, Mike Gibson, Christie Ballantyne coming to you live from ACC 23, and we're talking about an oral PCSK9 agent. Christie, I thought this was not druggable.
You know, I was told the same thing maybe, I don't know, a decade ago that you couldn't do this. So this is it's a pretty cool story about how biotechnology has led to so many advances. You know, we have fully human monoclonals, we got siRNAs, and now they screen this they screen a macrocyclic peptide library, 10 to the 14,
Wow.
with an mRNA screening methodology to find, and then there was a tremendous amount of, once you found something, is modifying the chemical structures to improve a number of properties so it could become an oral molecule. So it's a really pretty cool story about kind of combining biotech with medicinal chemistry for it. And so here we go. You know, we have a phase 2 study.
So who were the patients and what did you find?
So one of the things I really like about the design of the phase 2 was to try to have a little broader and more inclusive. So it was a 4-to-1 randomization, so 5 groups in the study, and it was a dose, looking at dose escalation. So it's 6, 12, 18, 30 milligrams versus placebo. The nice thing is it was 49% women. So for a phase 2, that's unusual.
That's amazing. Great.
It's about 75 per group, 40% Hispanic, 16% Asian.
Right.
So, you know, it was more diverse than usual with it. And it was a mixture. Coronary disease was about close to 40%. High risk was over 50%. There was some also in that 5 to 7.5 lower risk. So a broad variety of risk. And they had different LDL criteria to get in. If you were lower risk, you had to be a higher LDL.
Right.
So it was, I thought that was you know, most of our phase 2 studies they're not trying to get as much of a diverse population. Right. So that was a very, to me, a nice aspect of the trial design. And also kind of makes us think more about where the future may be with this agent.
And then what did you see?
So the primary endpoint, LDL cholesterol, but even at the 6 milligram dose, it was over 41% reduction. Wow. And when you get up to the 30 milligram dose, it was 61% compared to placebo.
Wow, 61% is impressive.
Yeah. So basically, the other one is the non-HDL and ApoB. ApoB was reduced about 52%, non-HDL around close to 56%. So really good reductions in all the key atherogenic parameters for this.
And what would be the advantage of an oral over a sub-Q agent?
You know, so one of the things that comes up is we're all aware, in terms of clinical practice, we haven't seen the same kind of uptake of PCSK9 inhibitors. And some of that may be because people don't want to have injections. A lot of it is the access issue with it. So I think the goal is to come up with a therapy that could be widely available to a pretty broad group of individuals to give highly effective LDL reductions that can be done on top of a statin. There were also some people who were statin intolerant in this study who also had very good efficacy.
Well, that's an important point. 61% on top of a statin.
61% with the majority on, and whether you're on top of a statin or, you know, not on a statin, was basically similarly effective reductions.
Amazing. Great work. Thanks for joining us. Thanks to all of you for joining us here live from ACC 23.